Okay, now we can. Okay, welcome everyone. Thank you for joining us this evening for another session, virtual Global Spine Conference session. I'm really honored. It's an honor for me to host my dear friend and partner, Dr. Najib El Tecle. He's assistant professor of neurological surgery and orthopedic surgery at Northwestern Medicine. He's a quadruple threat. So quadruple threat, he has a background in biomedical engineering and master's in that, and an MBA, extremely superbly talented surgeon. His expertise in deformity surgery and tumor surgery, in addition to minimally invasive surgery and endoscopic robotic. He's an educator, so quadruple threat: leadership, education, patient care, and an excellent researcher. So tonight he will be speaking with us about evidence-based spine surgery. I hope you enjoy the session. It's pretty interactive, so if you have any questions, I'll be looking at the chat box and trying to address as many questions as I can as we go through this. Thank you, Najib, for joining us, and the floor is yours.
Thank you, Nader. That's a very kind introduction. It's a pleasure to be here with all of you tonight. This conference series has been a great resource for me and for many others, starting during the pandemic and until today. Again, I'm thrilled to be here, and I wanted to talk about this topic that I think is very important for the practice of surgery in 2023 and going forward, and that is evidence-based spine surgery. In a way, we're trying to answer the question of why do we do what we do, and what can we do about the way we do things. And if you want to look a little bit deeper, trying to understand what's evidence-based spine surgery, we need to take a look at the history of medicine. Starting with the history of medicine, many know that for a long time, medicine had a largely negative balance sheet. What does that mean? A negative balance sheet meant that going to the doctor increased your chances of dying. And many think that the inflection point happened in medical history when the penicillin was discovered and subsequently mass produced. Many think that up until that point, we were still putting patients at increased risk by doing the interventions that we do. And if you're wondering about other examples, how we did that, look at these. For example, on the left side, you can see the cheapest specific for the relief of coughs. You can purchase an ounce for $4.85. And on the right side, you can see that what we recommended, like different brands of cigarettes for a long time. Other ways that we practice medicine, if we want to look at the history of spine surgery, whether we did hang patients by their legs in an attempt to adjust their scoliosis, or walked on their backs in an attempt to reduce their back pain, or similarly, these fancy braces and traction devices that for us modern spine surgeons look like they come from, or they look like medieval torture devices. Now, also in the broader spectrum that is neurosurgery and orthopedic surgery, we did crazy things, or what in modern day standards are crazy things, going through the eyes to do lobotomies, cutting through the white matters, or doing finger dissection to get tumors out of brains, or these fancy orthopedic devices that look like medieval torturing devices that were designed to reduce fractures. And if we want to ask, why did we do that? And how did we come to that point in medical history? We need to realize that in many ways, our history, the history of medicine, has been driven by biases. What are biases? Cognitive biases are just deviations from what would be considered absolute normal logic. So what are these biases? I'm going to talk about three common ones. One, intervention bias. What is an intervention bias? It's our human nature where we are doers. We are inclined to do. You hurt your arm, you go rush, put some ice on it. You want to do something, you have a hematoma, you want to get it out, etc. That's our human bias to do, as opposed to watch and see what's going to happen. The other bias that's common in medicine is the optimism bias, which is the thought process that I am less likely to experience a negative event than other people. That bias is, for example, why most drivers, more than 50% of drivers, think they are in the 90th percentile of the population in terms of their driving skills. Similarly, more than 50% of surgeons want to think that their skills are put them in the 90th percentile from a performance standpoint. And finally, the confirmation bias is seeking out information to confirm one's beliefs. That's the bias that most of us, anytime we write a paper, in a way, we are trying to confirm our beliefs and try to show that, okay, what I think is right is absolutely right. Now, the moment we started realize that we have biases, that's when we started thinking about what can we do about it. And that's how the concept of evidence-based medicine emerged. Ancient medicine was mostly based on authority, apprenticeship, anecdotal evidence. But in the Enlightenment period, that's about the 1700s, there was that emergence of skepticism about authorities. And in 1747, that's when what is considered the first modern clinical trial happened. That's Sir James Lind on the left side. And he randomized sailors who had scurvy to, he had 12 sailors, he randomized to six different groups, and 2 of the sailors got citrus. Their scurvy resolved, and that was the discovery of what later would be determined to be vitamin C and its impact on scurvy and vitamin C deficiency. Eventually, in the 1900s, we started to go to randomized clinical trial. The word evidence-based medicine was coined in the 1990s. In the modern period, we started transitioning to databases, AI, and that sort of approaches to data in medicine. But the statistics in therapeutics, or using numbers to describe therapeutics, has had its opponents for a long time. Since the 1800s, when people started talking about using statistics in therapeutics, there were significant objections. Old school objections fell in the category of, okay, we should not replace what is considered certain medicine by probability, by numbers, and we should acknowledge the individuality of the patient. Numbers cannot represent variability, and in a way, there is the art médical that we need, that is the time-honored practice of medicine that should be respected. And there were what were at the time considered modern objections that, well, using numbers to describe medicine is practically unfeasible, it would be clinically inadequate, and that it would be methodically insufficient. Still, despite the objections, as a field, we made significant progress. And in general, in medicine, we made significant progress. That culminated in 1984 by the British Medical Journal publishing the first randomized clinical trial. That was a trial of streptomycin treatment of pulmonary tuberculosis, randomized patients, and that became the foundation of what at the time became the modern treatment of tuberculosis. In neurosurgery and orthopedic surgery, we took that leap later on. The first trial in neurosurgery or randomized clinical trial was in 1960s. Patients with ruptured posterior communicating aneurysms were divided into 2 groups, those that were treated conservatively and those that underwent surgical treatment. The conclusion of those trials do not apply today, but still some numbers from that trial, such as the rate of patients that pass from these diseases, etc., are still quoted to this day. On the orthopedic side, the first trial came a few years later in 1964, and that was a trial of early weight bearing after internal fixation of femur fractures. Similarly, conclusions do not apply to this day, but many of the numbers that came out at that point are still relevant. And the specific field that is spine surgery, our first clinical trials came out in 1974, and those were trials of the treatment and surgical management of patients with spinal tuberculosis. Subsequently, and since then, we have done significant, there have been significant improvement in the field. We recently investigated the total number of clinical trials in spine surgery, and we found that since those first trials, there have been 557 trials that have been published in general, covering general spine topics. 47% of these trials were about degenerative spine diseases, anesthesia, pain, spinal cord stimulator, almost 41%, and about 4% of trials were about trauma, SCI. The rest fell in the categories of infectious diseases and etc. Now, in many ways, looking at these trials, we can say that spine surgery trials were less grandiose than their medical counterparts. Every time you see a medical trial, you see thousands of randomized patients, conclusions that are in ways earth-shattering, and But for us in spine surgery, the numbers are smaller, and each trial has taught us something. For example, the NASIS, the steroid trials, taught us the challenges of multiple subgroup analyses when it comes to randomizing patients. The sport trial, or the series of the sport trial, showed us the challenges with randomization and the challenges of using intention to treat analysis for surgical patients. While intention to treat analysis is by many ways the gold standard of how clinical trials should be analyzed, many surgeons found it hard to accept that a patient that initially was randomized to a non-surgical treatment ended up with surgery should be interpreted and included in the analysis as a patient who did not undergo surgery. STASIS is more recently a spinal cord injury trial about timing of surgery in the setting of spinal cord injury. And from that trial, many questions came up about what degree of evidence is enough to make a certain clinical recommendation. Most recently, the Swedish trial and the Gowalla trial about spondylolisthesis in the New England Journal of Medicine in 2016 taught us a lot about generalizability of results in surgical clinical trials. Two trials designed in many ways, in very similar ways, came up with two different conclusions, and that taught us a lot about the limitations. And in general, when we talk about surgical trials, there are limitations, and these are acknowledged by many. So one, there's a huge number of surgical procedures, and if we want to randomize if we want to create a clinical trial for every single one of these procedures, in many ways, that's practically unfeasible. Second, there is limited time, limited resources. There is also the skill dependency of surgery. When we're randomizing patients to surgery, no two surgeons do the same surgery, and even the same surgeon doing the same surgery on different patients is doing a different surgery in many ways. And that also adds the nature of to the nature of the surgical knowledge. In a way, when the outcome is close to the intervention, yes, that's easy to assess. But if we need to look at things down the road, then you need better design, then you need more funding, you need to be able to follow these patients longitudinally. Still, we made progress, and trials became gold standard in many ways. And there have been, since the 80s, many other issues that have been addressed in the way we do standard reporting. For example, Cochrane came out in 1992. More recently, Consort reporting for structural abstracts and RCTs, the Clear NPT and Strobe. All these became standards that helped us make more sense of data in spine surgery. As part of the work we've done, we looked at the most influential papers in neurosurgery in general and published this book that includes 70 papers. Each one has structured summary of the paper and 2 editorials per paper, looking at what is evidence-based neurosurgery, what's evidence-based neurosurgery like in the 2010s and later on. But by far the strongest effort in neurosurgery to come up with evidence-based recommendation has been done through the practice guidelines that came out through the AANS and the CNS. Those started in 1993 when the Brain Trauma Foundation approached the AANS to join forces and work on clinical trials and clinical recommendations. Eventually, many projects came out of that, and since then, several other projects have came out of these studies. There have been separate guidelines that came through AO Spine. There has been a large issue that was published in 2017 showing a large number of clinical guidelines by AO, and NAS has had its own effort for clinical trials. But at this stage, you might wonder, okay, we have these wonderful clinical trials, very useful resources for patients. Why not do more of them? And I can tell you about my personal experience. I got to work on the clinical trial for ICH with Dr. Bernard Bendock back in 2012. And at the time, we were talking about recommendations for surgical treatment of intracranial hemorrhage. And to come up with this sentence, for most patients with supratentorial ICH, the usefulness of surgery is not well established. Class 2B level of evidence A, that required significant time, and it took a while to get that through the committees. And other limitations of why we cannot do more. Trials cost up to $100,000 prior to publications, and that's when relying on volunteer work. It takes on average 3 years for those trials to be completed. And at the end of the day, your outcome is not necessarily something that's variable for long duration. The relative shelf life for evidence-based medicine clinical guidelines is about 5 to 7 years. So all that works, and in 5 to 7 years, that evidence is not going to be sufficient to make really sound recommendations. Just to take a moment to look at, in general, what do we mean when we look at these trials or at these recommendations? Most trials that report according to modern standards are going to report on a strength of recommendation. That's the conviction that a certain intervention is going to cause benefit more than harm, or the other way around, that determines the class of the recommendation. And the level of the evidence is going to be how strongly convinced and what evidence do we have to support said recommendation and said strength of recommendation. For example, if we look at this guideline for timing of surgery following spinal cord injury, acute spinal cord injury, this is one of the guideline papers that came out from AO in 2017. If we read this first recommendation, we suggest that early surgery within 24 hours after injury be considered as a treatment option in adult patients with traumatic central cord syndrome. Quality of evidence low, strength of recommendation weak. You see, there have been a ton of research done about that topic. There have been a clinical trial done about that topic. And still, the extent to which you can make such a recommendation is with low quality of evidence and weak strength of recommendation. Similarly, for the second recommendation, for patients with spinal cord injury, regardless of level, the quality of evidence is low, the strength of recommendation is weak, despite all the work that has been done on this topic. And that's why there have been significant challenges in pushing this field of evidence-based spine surgery forward. To answer more questions about how has evidence-based spine surgery been progressing, if we were doing a better job, if we were doing a good job, we should notice diminished variability in practices and improved research reporting. We decided to look at these two questions. Part of the work we did, we sent a survey to neurosurgeons and looked at how or what they do after simple surgeries, 1 and 2 level ACDFs, lumbar microdiscectomy, short and long fusions. We looked at whether they brace their patients when they ask their patient to return to work. And let me take a moment to ask the audience, if anyone wants to tell me, does anyone brace their patients or put the patient in a neck collar following a single level ACDF? And I'll tell you about the results.
Yeah, you can go ahead and answer in the chat box if you brace or not. You know, assuming, let's say the patient does not have osteoporosis and undergoes single level ACDF, do you guys brace or not? So no.
And there's one yes.
There's one yes. Do you brace, Najib, after a single level ACDF?
Not always, not always. If I have any concerns, yes, but in general, no, for a single level. 2 levels, I do brace. However, for example, where I trained, we wouldn't brace for even multiple level surgery.
Okay, looks like the answers are congruent with the results of your study.
Yeah, in many ways, they are congruent with the results of the study. And that shows a lot about, we really don't know what the right answer is. It's either we don't know what the answer is, or it really does not matter. And if it does not matter, then we should be going for the cheapest alternative that is that has less impact on the patient's life. And that's one of those things. How do these practices propagate? It's by training, by school of thought, by, okay, I trained with this mentor who does brace, so I continue to brace, and things like that, where, yes, it's almost as if the results were 50-50, not only for the single level ACDF, but for the 2+ level ACDF, the results were 50-50. Almost 50% of surgeons did use a collar and 50% did not use a collar. Similarly, we looked at when do surgeons let their patients return to work following a single level ACDF, and the results were, and here, let's take a look, see if what people typically do. Say you have a patient with a single level ACDF that is going back to a sedentary type work, when would you let them go back to work? Immediately, within a week, between 1 and 2 weeks, or after 1 month or longer?
Yeah, so let's say an office job after a single level ACDF. When do you let them go back to work? Less than 4 weeks or more than 4 weeks, like within a week, 1 to 2 weeks. So 4 weeks after ACDF. I actually do the same for an office job. I'm just more on the conservative side. And if a patient is a laborer, you know, maybe I'll take even more time. Pretty conservative. I'm a conservative person. So yeah, so I agree. Depends on the work. Imran's saying, I agree with that. So obviously it's a sedentary job. Let them go back earlier. If it's something that's labor intensive, maybe take more time, but it's still variable.
Right.
Even within the same practice, it's variable. Even within the same provider is variable, depending on the job, bone quality, maybe preoperative symptoms.
Exactly. And when we ask that question, we ask like specifically into 3 groups. Patients who have sedentary type work, patients who have like work requiring moderate activity, and patients who had work requiring heavy activity. Now, when it came to patients who have like office style work, most surgeons let them go back between 1 and 2 weeks, but still 10%, almost 10% of surgeons let their patients go back to that type of work almost immediately after the ACDF, and 10% ask them to wait longer than a month. So again, that variability, okay, we don't, if it tells us something, it tells us that we don't know what the right answer is. And if we look more at this data, there are socioeconomic ramifications in the sense that these are work days lost, eventually that affects the whole economy, et cetera, et cetera. And other than that question, and I'm not going to bore you with all the numbers or ask you about all the numbers, but when it came to return to work, when it came to return to exercises, when it came to wearing neck collars for single level ACDF and for more than 2 level ACDF, the common denominator was significant variability in between patients. And it's not only in the practice of these simple things. Other groups looked at a similar question. For example, in this paper here on the left side, the authors looked at anticoagulation. How's our practice of anticoagulation, or how does it vary nationally and internationally? And the main thing for them, they reported significant variability between continents, between regions, and even, for example, in neurosurgery, the way we declared patients brain dead, that's a very important topic, and there was significant practice variability. Now, the other question that I had asked before is, if we are making really good progress, we should be seeing improved reporting. So in order to look at that, we had 2 options. One, you go back and review all the surgical literature and see if there are any mistakes in published literature. Or the alternative the route we decided to take is to look at a surrogate for statistical errors in papers. And we use this trend towards statistical significance, the use of trend towards statistical significance in papers as a surrogate for the presence of statistical errors. And that can be a very long discussion, but in general, why is it trend towards statistical significance, or the use of such a sentence around statements? Because if you think about it, if you get the p-value of 0.049, you would not be reporting that as tending towards statistical insignificance. And there is a much more intellectual debate that can be had about that. But for now, and for the sake of time, we looked at what papers that were published in Neurosurgical Journal contained the statistical error. And it's, to our surprise, almost 1.5% of all papers published in the neurosurgical literature contained this error. We stratified by journals, and for a certain reason, ACTA, the European Neurosurgical Journal, had fewer errors than the rest. And for us in spine surgery, we had almost more errors than the rest. Looking at which specialties had more errors: spine, tumor, and vascular, and neurosurgery. But in many ways, this reflects the number of publications that are published, like in terms of relative numbers among specialties. Now, we've been making some progress, but in general, recently there have been publications questioning the nature of evidence-based medicine. And the same journal that published this first paper on the first clinical trial published this this opinion about the illusion of evidence-based medicine, where people talked about why the way randomized clinical trials are currently conducted is an issue, and why what are the limitations that we're facing. And this famous paper, why most published research findings are false, like showing with mathematical proofs that a lot of the papers that are going to be published and make it to journals have a post-test probability of being false, and have a post-test probability that their conclusions are false. Another concern that came up is, okay, we are doing randomized clinical trials. The goal of these is to look at a population. And at the end of the day, we take those results from the population and apply them to the individual. So in a way, we're trying to do precision medicine, but we are studying populations. And for anyone who does statistics, you know that an individual and the population are on totally opposite spectrums of the analysis. And in many ways, the question that comes up is, are randomized clinical trials the right way going forward? Are these trials the right way to answer questions about the individual, or are they better to answer questions about the population? And in that case, how do we come up with our conclusions about the individual? So with all these limitations, the next question that obviously come up is, can we overcome these limitations? Can we, are there any ways to work around these limitations? And in many ways, I want to think that the answer is yes. So let me first talk about the emergence of big data. What is big data? Big data is not simply like a large data set. Yes, a large data set would constitute big data, but big data in many ways is a data that has a low signal to noise ratio. So it's a huge data set where the signal, the piece of information you're looking for is just hidden in that big data set, and the rest is just big noise. So with big noise, that requires new ways of processing that data, new analysis methods, and that's the AI stuff and all that stuff that's emerging. Many argue that, okay, these technologies are great, but in many ways they are black box technologies. They give you an outcome, they give you a result, but you cannot tell how you're deriving that result. And from that standpoint, there have been significant research trying to show how do these AI algorithms come up with the answers they give us. That's from a signal to noise ratio standpoint. Now, also many argue that big data, then that's a problem of garbage in, garbage out. We're collecting all this data in a very random fashion. We get all this data from electronic health record. We get all this data that is collected in haphazard ways and try to come up with valid conclusions. And I think going forward, we're gonna improve all of this stuff. So starting with the signal, I think the way we're collecting signals is definitely gonna change. Now we rely on patients reporting reported outcomes, right? We rely on asking the patients, hey, what's your pain level on a scale of 0 to 10? But now with all these technological devices that that have been developed and that are in many ways becoming ubiquitous, whether it is something you wear on your watch, you put it on your pocket, or whether it's an implantable subcutaneous device, all these are going to help us have better signal. And all these, the big data problems are going to be, the big data is going to be more rich with really good signal, and we're not going to be facing as much garbage in, garbage out of problems. Now, that's when it comes to collecting objective data about the patient. But also there have been an emergence of newer technology that will help us with better collection of patient-reported outcome. Many of you might be aware there are like deep scribe technology where now a computer is listening to you doing your interview in your office, and then they're gonna come up with the note. And similar technologies are gonna be able to eventually help us better figure way, better report these patient outcomes, these subjective outcomes that we have no way to quantify. And if you want to think a little bit about how is that improving, I think taking a look at a novel system that has recently been became available by a company called OpenAI. It's a system that's called ChatGPT. In a way, it's the model that predicts text, and how that system is able to interview patient is really fascinating. I'm not going to take you through a patient interview, but I'm going to take you through this example of me taking ChatGPT through some board questions and asking ChatGPT. This is a totally AI system. Like it's a system that's based on certain predictive models. We're not going to go in the details, but asking like, what's your differential diagnosis for a patient presenting with back pain? And this thing that supposedly has no intelligence, nothing that at all, comes up with, okay, that's my differential diagnosis. You have to like guide it in a way because it is designed specifically not to give medical advice, but like you can ask it about, hey, describe the steps of the surgical procedure. And then it tells you, okay, these are the steps to do a lumbar microdiscectomy. Then you can tell it, hey, please elaborate further on this step. And then it describes specifically how to do your laminotomy and how you get your disc out. So this type of technology is definitely poised to change the way we collect data from patients. This is something where a computer can simulate a physician and collect those patient-reported outcomes. And in many ways, we improve the way we collect these outcomes. And that eventually feeds back into our model of evidence-based spine surgery. And that's how we can overall improve the results and improve the ways we can help our patients. What I want to talk about next is simple. In the beginning,
Najib, quick question. So
go ahead.
Let's say you want to use that AI platform. Can you write a review on os odontoideum, for example? Like,
absolutely.
What's the word like? So what's the word limit? I mean, when does it stop? like you have, and does it reference it? I mean.
Absolutely, you can do that. And there are models trained specifically on academic papers where they can generate like really nice academic paper for you.
Oh, wow.
And that's where we're going to have a problem because, okay, now this is at the level of a high school student. They have an essay. They need to write an essay. They go type down the title, and then they have the essay and they submit it. But soon they're going to be, yes, less than 10 seconds. And soon they're going to be like, that valley between true expert and false expert is going to disappear. You're like, I can pretend to be an expert about anything. I just ask ChatGPT, or eventually now GPT-3 and GPT-4 is coming out this year. And these are like systems with trillions of neurons, or the equivalent of neurons. You can go and ask them to write a book for you, and then you're suddenly the author of a book and you're a published author. Things like that, where they're going to be, the difference between a fake expert and the real expert is in many ways going to disappear. And in many ways, you won't be able to tell, like, okay, what the reality is. But still, I think from a medical standpoint, we can use this emerging technology to improve the way we collect data, to help us process data in much better ways, and eventually to help our patients.
Yeah, I think of this too, like, I don't know if that's doable as of yet with that AI platform. ChatGPT is a meta-analysis. You know what I mean? Would they do statistics, or because that can happen, right? Like, you know, why not? If you have like performing a meta-analysis, and the evidence behind the meta-analysis is as sometimes superior than a clinical trial meta-analysis, right? Like, what is that possible as of now, or what do you?
Not yet, but I'm sure that will be possible very
possible in the next 3 months. Very soon. Like, wow, that's pretty impressive. Like a platform, you come up with a question, let's write a meta-analysis on outcomes following surgery for spondylolisthesis, right? Like, you know,
and then you'll have like first author ChatGPT, senior author.
Yeah, it's like, but it's in, that's we're witnessing really exciting times. Really lucky.
Well, and let me see, I think I saw a question coming over in the chat.
Yeah, Dr. Tecle,
that's a great. That's a great question, because again, we're talking about, so to train these models, you're generating, eventually what these models generate is something similar to what they've been trained on. And as long as the ground truth is not like really solid, then whatever they generate is based on said ground truths. And that's again going to the model of garbage in, garbage out. But at the same time, what these models are going to do over the next few years is they're going to improve their ground truths. They're going to improve our ground truths. They're going to improve our ability to report. And it's going to be like a positive feedback loop where we get better outcomes, where we get better reporting, and eventually we're able to do a better job, and it keeps on improving. I really think that's how it's going to move. It is not going to be, yes, if we ask a model at this stage trade on the PubMed data, or what's apparently called PubMed GPT, that's a great model. If we ask that model to currently generate a paper, the paper is going to be limited by the data that's available on PubMed. But as we can keep improving everything, we're going to get there to a point where this scientific data is building up on its own without us even intervening as humans. Which brings me to my next slide, which is about our cognitive limitations. I did talk about in the beginning about 3 cognitive biases that are common in medicine, but at the same time, there have been more than 180 cognitive biases in medicine. And whether we like it or not, we are all subject to these biases, and we try to train to get around them. But at the end of the day, the way we make decisions is through our own subjective lens that we use to look at the universe, and that we use to look at the medical data. And which brings me to another point, that is, again, the uniqueness of the patient. We talked about the discrepancy between the patient and the population. And like, these are some of the challenging cases I had in the past couple months. But like, when you look at the sacral fracture, there are not going to be that many of these sacral fractures that you can use to draw conclusions and to recommend the best possible treatment. When you look at this patient with Parkinson's disease, chin on chest deformity, osteoporosis, compression fractures, it's not going to be, there's going to be no data, at least not in the near future, to tell you, okay, that is the best treatment for this patient. And when you look at this patient's had 7 lumbar surgery, the last one was complicated by a fungal infection and came to me with a really terrible back pain. There also, it's going to be hard to be able to go back and say, oh, look, this is a report of 100 patients that had the same surgery for the same reason, and look how they did. I think the best possible treatment is that is the best possible treatment. And I'm gonna again go back to this slide. So a very important point to note is that between these practices here and these practices here that are state of the art and that are really making a huge difference to our patients, there's probably less than 100 years. And we should be proud of what we have to offer our patients today. It is absolutely fascinating what we can do to our patients and how we can treat their spine problems. But at the same time, and that's my last idea, we need to keep in mind that in 100 years, people are going to look at what we're doing today the same way we look at these things. And that's going to be great for the patients of the year 2100. But it is our job to create that future where these technologies become obsolete and where the treatment of spine, or where spine surgery is really something different and really way more helpful than it is today. Thank you for your attention, and I'm happy to entertain any questions as they come up.
Thank you, Dr. El Tecle. This was a fantastic, very valuable virtual seminar. Really summed it up beautifully in 40 minutes. So I agree. I think, I have a few points. One pertaining to clinical trials. It's important, as you mentioned, you're talking about internal validity, then external validity, where the sample is from the population, and then we have a lot of exclusion criteria. okay? And however, still there will be variability in terms of the practitioners, you know, a lot of heterogeneity and with that, and then you get the outcomes and you draw conclusions, and then it's not necessarily applicable to the general population, you know, because of the exclusion criteria. I think that's something that's very difficult to overcome, especially in spinal surgery. You know, it's very difficult to overcome. There are no, you know, it's just the issue with the heterogeneity and the exclusion criteria. One thing that I think is important as a surgeon is just to track your own outcomes and just ensure that you're practicing within the frame of evidence-based medicine. However, you got to track your own outcomes and make sure you get better with time, and your outcomes are as good or better than the average reported in the literature. Really owning your outcomes and keeping track of them is really important. And that's how you know if you're getting better or not as an individual. And I think it's not an easy task because we're very busy and but we need to be owners of our own outcomes that are as objective as possible, like objective outcomes, PROMS outcomes. So that's one thing that I'm trying to incorporate in my practice. I have been. So it's just, am I doing a good job or am I not doing a good job? And am I practicing within the framework of evidence-based medicine? And, you know, am I getting efficient? Am I getting better? Is my correction adequate? So that's an important thing that as human beings and individuals surgeons should probably pursue. Any questions in the chat box? Do you think in order to get closer to individualization of research, we will need to incorporate the genetic profile of diseases and patients in research? What do you think, Najib?
Absolutely. In many ways, that is the whole purpose of precision medicine, like patient-specific treatments that are maybe specific to whatever their genome is or things like that, whatever proteins are expressed in their body. I think in many ways, the future of spine surgery might not necessarily be surgical, and it might be biologic. It might be that you could do things to prevent scoliosis from happening. You could do things to significantly slow down degeneration. You could medically treat the herniated disc or something like that. A future that is yet to be imagined, but it is very well possible that the future might not be surgical in many ways. And maybe not the future in 100 years, maybe the future in 500 years, but that's what we cannot predict that far down the road, because it will be things that we did not even imagine. The same way, if you ask someone in the early 1900s what things would look like in the year 2000, they would probably have imagined faster horses and better trained horses and things like that, where the future we had was totally different: planes and cars and electrical cars, etc., etc. So it's very difficult, and that's what's defined by what's the adjacent possible. For us now, the adjacent possible is robotics, a robot that does surgery on their own, neuromonitoring happening on its own, great imaging technologies, augmented reality, endoscopic surgery. That's the adjacent possible, what's possible for us. But no one can predict when a big, like a black swan event happens in the world of research, and then the whole future changes. Then you can potentially treat things medically and things like that. I think it is hard to predict how that's gonna go, but yes, as long as we keep engaged in research, we keep pushing our field forward, there gonna be some biologic solutions. Incorporating genomics and things like that are gonna become part of spine surgery in the very near future.
Excellent. You know, at the end of the day, we're human beings who want to achieve our potential in everything we do. Research is still important. You gotta always, when you read a paper, you want to really vet it. You want to understand, not just look at the conclusions, look at the methodology. You know, because if the methodology is erroneous, then you can't fix that with statistics. Then you throw the study in the garbage. But so being well versed in statistics and being acquainted with how to vet and approach clinical research is important as clinicians. You know, we want to use evidence-based medicine. However, we need to be able to understand and vet what's a good paper, what's not a good paper, and so forth. Okay, thank you, everybody. It looks like we're wrapping up right now. I can't thank you enough, Dr. El Tecle, for joining us. One of many.
Thank you for having me.
This is a very valuable lecture, and I thanks everybody for being with us this evening. I don't know who's presenting next week, but we will. But in the next few days, we'll put a flyer on the next host and the next invited speaker. Until then, I wish you a great weekend and great rest of the week, and then a great weekend, and we'll see you soon. Bye.